Come back. I'm glad you're still with us. We have allowed the politicians to go and pour some water on the flames of politics. We hope the corridor is calm right now. Now, let's go into our Take Note discussion. Pandemic prevention, preparedness and response agreement. I'll be introducing my guest very shortly, who is going to do a lot of raising awareness to some of these issues. But on May the 20th, 2025 in Geneva, the World Health Assembly, the decision-making body of the World Health Organization, adopted the first ever WHO pandemic agreement, bringing to a close years of negotiations triggered by the painful lessons of COVID-19. It was not perfect, but it's work in progress. The question now is, what next for Uganda? And here to speak to us is a public health advocate and programs lead, We Rise and Prosper Up, Ezra Meme. Many thanks for joining us this morning.
Thank you, and thanks for having me.
Great. I see WHO pandemic agreement. But before you answer that, We Rise and Prosper is...
It's a civil society organization.
Civil society organization.
Yes.
Tell me about your work.
Well, we promote advocacy in various things, beginning with HIV, and then now you can, as you have invited me here, pandemic preparedness and things related to that, yes.
All right. So what is this WHO pandemic agreement?
So it is an agreement, like you have said, that was signed that kind of guides how countries respond to pandemics, because pandemics affect countries all over the world, so it is important that the world together comes with some kind of agreement on how to deal with what happens when it strikes. Yes.
All right. So what is Uganda's prong in as far as this agreement is concerned? I see this particular development apparently bringing to a close years of negotiations. Uganda must have had a stand.
Yes.
And
so
does the agreement meet what we negotiated for?
Yeah, we negotiated as a bloc, so it's not really Ugandan as I say, but you keep grouping yourselves. So yeah, what this means, previously countries were being governed by international health regulations, but these were not legally binding. So the pandemic agreement is now a treaty that countries must follow as part of international law. So that is the difference. What that means for Uganda is, for instance, rapid reporting. We are expected to report when we have a pathogen that we have found within 48 hours. But it also means that we will have ring fencing of funds for labs and cold chain. Cold chain is how we refrigerate and store
the medicines.
Yes, until they're used. But also for labs, so that at a district level, for instance, you have their hospitals having PCR machines and staffing to ensure that they can be able to test on site instead of shipping samples several kilometers away. But it also means that we will have real-time access to vaccines under a PABS mechanism. PABS is pathogen access and benefit sharing, where if Uganda uploads the genomic details of a pathogen within 48 hours, then it guarantees that the manufacturers will give us a slice of the vaccines and treatments when they do manufacture. Then you'll be guaranteed 20% because it is data for doses. You gave data and now you are entitled to at least a slice, let's say 20% of the doses. So in a nutshell, we will benefit because of these agreements' emphasis on health systems, strengthening and surveillance, but also it comes with new demands. Like we have talked about, you have to do the labs upgrades, you have to spend a bit more in surveillance. So for a country that is spending only 6.5% of its budget on health, these cost implications will exert a bit of a burden. Now, with regard to integration of interventions, we see the HIV, should I call it a pandemic? Yes. Has long ravaged our core as a society, and many times there are interventions that are designed for new approaches to attend to the new challenges. We now have the rollout of
and a vaccine that can be taken 2 times in a year.
Yeah.
Does this fit within the broader pandemic preparedness framework?
Yes, it's important to integrate HIV in the broader pandemic framework, because in a situation where you have 1.4 million people living with HIV and about 1,000 new infections each week,
that's right.
HIV has become part and parcel of our health sector landscape. So, and what we learned from COVID-19 is that if you focus just on the pandemic and allow it to disrupt HIV services, then what happens is you will have a catastrophic impact that will be worse than even the disruption. Because, for instance, if you're having, you are not able to provide HIV testing services, and let's say that means that people who could have probably started treatment are now not starting treatment. Those who were depending on consistent treatments are now having drug resistance that is being developed because we had lockdowns and things like that. So these are impacts that you face long after COVID is gone. But then there's also the infrastructure, because the HIV response is, I think, the most sophisticated infrastructure development that our health system has. If you look at the lab capacity that the HIV has, JCRC, for instance, had a lab that was initially used for HIV care, which could pivot to do testing for COVID like it did. But also when you look at the community systems, the HIV programs have very extensive community system. You have peers that go door to door giving drugs and supporting treatment, and these are things that can be used in a pandemic. But also you have service delivery models in HIV, things like community distribution points and mobile service delivery in which reach hard to reach areas. And these are things that we can leverage on in a pandemic. So yes, it's really important to have these synergies and also ensure continuity of care so that we do not have the adverse effects. Okay,
I'm glad you used the word synergies, because it directly takes me into the very next question about linking human, animal and environmental practicability, especially in what is called the One Health approach. Talk to us about that.
So the One Health approach is where you have different components, like you have said. There is the animal, the human. What this would look like, for instance, at district level is you will have an epidemiologist and a vet officer and a wildlife officer working together.
That's right.
Such that if we are having bats in a national park that are being tested to see if there is any risk that may be translate to human disease, and we're having cattle that are dying, for instance, at abnormal numbers being tested. All these things can link to, if this team is sharing data across each other, we can say that, hey, there are unexplained deaths among monkeys in Queen Elizabeth, and that might pose a human threat.
That is right.
But beyond that, you also have the joint working together when it comes to ordinary implementation. If we can pull together, maybe through Parliament, that one basket of resources. Instead of each of these different ministries, you have Ministry of Water and Environment, you have Agriculture, you have Health, having their separate pools of funds, and you have them pooling together to ensure that we leverage, because when it comes to health, we have a national laboratory which WHO considers to be quite a gold standard, a center of excellence. But we have to have...
That is within sub-Saharan Africa?
Yes, but within, we have to have the veterinary capacity also match this capacity. We need to have our labs for cattle farms. You can't have a lab for cattle farm that is lacking running water and have, so we have to make sure that the environment tests can be done. We have the resources for that, that the staff in the vet can also be done, so that the One Health is actually operationalized, so that it is not leaning more towards one side, because of how important it is that we all work together.
Now, in all these, funds are important.
Yes.
The World Health Assembly, the governing and decision-making body of the World Health Organization, has come under increasing pressure, especially in light to concerns from Washington. about funding. The fact that the United States, I don't know whether it came through on its threat to withdraw support.
Yes.
And then the increasing realignment of priorities by donors and other countries in regard to what we've been receiving in terms of funds to help implementation, execution, but also monitoring of all these interventions. How are we dealing with that reality?
So there are different ways, of course, like you have said. The cutting of USAID funding set us back maybe 480 billion and of HIV funding, which is a really big impact. And it starts with the appreciation that we have such a huge gap, because then that makes you go into how do we cope. There are short-term ways in which you can cope, but then there are also long-term ways, medium and long-term ways. If you have, for instance, that appreciation among the public about the need to swiftly close this gap because of the ripple effect of things like that, they can be open to short-term mechanisms. For instance, we might innovate something like 0.5% on a tax of, say, mobile money. And because I think it was last year.
URA is watching.
Yeah, but I think it was last year when I think Bank of Uganda reported that the transactions were about 191 trillion shillings. 0.5% of that is about 100 billion. Even if we have exemptions and things like that and collect only 50 billion and use that as part of a seed funding to kind of bridge the gap, that would be something. But then there are also health levies. There are
health levies?
Yeah, like taxes on certain products.
That's right.
Cigarettes is a unique product which if you use it as expected by the manufacturer, you will end up with cancer. Lung cancer. So you find that things like cigarettes and alcohol are things that if you tax have a double benefit. Because if you have 20 bottles of alcohol and I take away one, I am improving your health outcomes by reducing the burden on your liver. But I'm taking that one bottle to convert it into funding that is going to build a health system that you're going to later need. So yes, we have made progress. I think it was in April this year that the Parliament agreed to double the taxing. That is after 6 years of not increasing it at all. So there are these short-term things that we already do have, but then there's also public-private partnerships. You can see how in COVID people were very willing to bring donations of whether it is matoke, whether it is milk and everything. Organizations, as part of their corporate social responsibility, can say, okay, maybe I'm a telecom company and I already have cars in all of these districts that are doing maintenance of my masts, and I'm going to help HIV prevention by transporting the health workers to go and do community outreaches. And then Ministry of Health says, I'm going to provide oversight and do the stuff, but then you will have helped bridge the gap that was caused by that. But that is short term. For things we already have. Medium term, like you were saying, we have long-acting PrEP now. If you're switching people from daily taking of PrEP to taking a shot once every 2 months, that first of all increases the uptake of those who are taking prevention services, but it also lowers the programmatic costs of having to do follow-ups of people who are taking daily. But then in the long term, we really need to up the percentage of our health budget from 6.5 years.
Mr. Ezra Meme, many thanks for what is no doubt very good insight and perspective with regard to the WHO pandemic agreement. It's quite technical, but you've broken down many things that the average Ugandan, including myself, can now comfortably say this is something that should be taken on, and all the cooperation needed, including public engagement. I hope there is a rollout of sensitization initiatives for the public.
Yes.
All right. Thank you very much. That will do it for the Tech Note, Pandemic Prevention, Preparedness and Response Agreement. And indeed, we'll do it for the program this morning or today. But we'll be catching you guys tomorrow. On behalf of the entire team behind the scenes, I'm Chris Higenyi. Have yourselves a lovely day.